I'd like to thank Jessica, Sarah, and the new team for the invitation. And today I'll be talking about multimodal neuroimaging to try to improve the outcome of the operative outcome of patients with drug-resistant epilepsy. And I'll be wearing two hats, the hat of a neurosurgeon and the hat of a researcher, because I'm also a clinician scientist. Yeah. So as most of you know, epilepsy is a prevalent disease. We're talking about 1% of the population in North America, which corresponds to about 300,000 Canadians and 50 million people worldwide. And early treatment of epilepsy is crucial, as untreated epilepsy can have an impact on physical, mental health, cognitive functions, and eventually quality of life of affected patients. While most patients respond to anti-seizure medication, unfortunately, there's about 1/3 of patients who do not. And about 10% of patients with epilepsy are considered surgical candidates, which corresponds to about 10,000 Canadians and 5 million worldwide. And surgery should always be considered in these patients with drug-resistant epilepsy because surgery can help control seizures in over half of patients and can lead to an improvement in quality of life in well-selected candidates. We face challenges in epilepsy surgery, and the main challenge is try to find the optimal balance between maximizing the resection, ablation, and disconnection to optimize seizure control, while at the same time preserving neurological function, especially near eloquent regions. And so to do so, we have neurosurgical tools, but unfortunately, these tools are imperfect. And one of the reasons for which these tools are imperfect is that they tend to overlook the underlying substrate of epilepsy. While historically focal epilepsy has been perceived as a localized cortical disorder, it's now been clear for the past 20 years that epilepsy is a pathology that is underpinned by an epileptic network involving both abnormal cortical nodes that are connected by aberrant white matter tracts. And so it makes total sense to study connectomics in order to understand the epileptic networks, considering the fact that white matter tracts are involved in the network itself. And to do so, a non-invasive way to do it would be using multimodal MRI approaches. And so an ideal adjunct for epilepsy surgeons would be one that would be non-invasive and that will take into account the epileptic network and reach the four following goals, which is to try to identify or help identifying the origin of seizures for better surgical targeting, try to predict postoperative seizure control to better select patients, prevent neurological complications, and predict postoperative recovery. Because if we know that patients with initial deficit will eventually recover, we can be a bit more aggressive, quote unquote, in our resection or ablation in order to achieve seizure freedom. And so the first objective is to identify the origin of seizures. And in order to identify the origin of seizures, it's important to understand the connectivity pattern of the region that might be involved in those seizures, since seizures propagate through white matter tracts. And one of the main interests that we have in Montreal is insular epilepsy. We've been studying it for many years, which is a type of focal epilepsy that originates from a deeply located structure, namely the insula. And so we've been studying the insular structural connectivity to try to understand seizure spread patterns and therefore help localizing the seizure onset. And so considering its strategic location at the crossroad of the frontal, parietal, and temporal lobe, it's not surprising that the insula is widely connected. Using modern tractography approaches, our team has shown that the insula is widely connected to all four other lobes following a rostrocaudal gradient. And this connectivity is both with the cortex and with subcortical regions. And so understanding the connectivity pattern of the insula is not only important to understand the functions of the insula, but also to understand seizure spread patterns, which could help describe or characterize the semiological manifestation during seizures and therefore help understand seizure onset zones. We've also more recently described the intrainsular structural connectivity, so the connectivity between insular subregions. And just like the connectivity between the insular and extrainsular structures, the intrainsular structural connectivity is important to understand seizure spread patterns, which could again help orient towards the location of the seizure onset. We can use some advanced neuroimaging tools, structural neuroimaging tools, to help map the network. And so what we've done in the past years is we used some structural connectivity approaches, troctography-based connectivity approaches, to describe the connectivity pattern in patients with opercular insular epilepsy. And what we found is that there's increased connectivity strength between the anterior insula and anterior cingulate cortex, as well as between insular subregions. We also studied the cortical thickness in these patients, and we found widespread cortical thinning, mainly located in the Rolandic cortex, the orbitofrontal region, the medial and lateral temporal area, as well as the insula. And so these patterns of increased connectivity and cortical thinning could potentially be used as structural signatures to orient toward the location of seizure onset, although obviously more work needs to be done. I'm proud to say that over the years, our team has put a lot of work into characterizing insular epilepsy, which was recognized in a bibliometric study in 2022. And I hope we'll be able to sustain our contribution over the years to better characterize and describe this under-recognized pathology. We also study in the lab temporal lobe epilepsy, which, as most of you know, is the most common type of focal epilepsy that's treated surgically. And one of the main challenges that we have in temporal lobe epilepsy is try to differentiate clinically 3 variants, which are isolated unilateral temporal lobe epilepsy, temporal plus epilepsy, in other words, type of temporal epilepsy that includes the temporal lobe but extends beyond it, and bilateral temporal lobe epilepsy or bitemporal epilepsy. And so unfortunately, standard tests fail to capture the entire extent of the epileptic network and cannot sufficiently distinguish those 3 types of variants of temporal lobe epilepsy. And it's important to differentiate them because their surgical strategy is completely different. While unilateral temporal lobe epilepsy are treated via resection, typically an anterior temporal lobectomy, temporal plus epilepsy typically require an SEEG before considering surgery, and bitemporal epilepsy are not resectable and you typically treated using neuromodulation approaches. And so we use a comprehensive connectivity pipeline to try to describe the pattern in those patients. And although the results are very preliminary, we got the results last week, what we found is that when comparing bilateral temporal lobe epilepsy to unilateral temporal lobe epilepsy, what we found is that there's an increased connectivity strength in connections on both sides, including interhemispheric connections between both temporal lobes. We also found that comparing TPE or temporal plus to unilateral TLE, there's increased connectivity strength between the medial temporal lobe and extratemporal structure, in this case, the rostral thalamus. So what we're showing is that both bitemporal and temporal plus epilepsy show stronger connections outside the temporal lobe. And again, although this is very preliminary, this could be used to try to distinguish the 3 types of epilepsy. And it kind of makes sense that both BTLE and TPE have a wider network because we know that the epileptic network of these 2 variants are larger. Another objective that we have is to try to, in the lab, is to try to 3-dimensionally depict as well as characterize the entire epileptic network, including the white matter component of the network. So using SEEG data from 20 patients, we classified all sampled cortical regions into one of the 4 following zones of the epileptic network: the seizure onset zone, the seizure propagation zone, the irritative zone, and a non-involved zone. And we combined that information with troctography-based structural connectivity data computed from a high-resolution DWI scan on those same 20 patients, so patient-specific DWI scans. And using, again, a comprehensive pipeline, we attempted to characterize the connectivity both within the zones of the network and between the zones of the network to both be able to 3-dimensionally depict the network, but also quantitatively describe it. This is just to show you a 3D representation of what we can do. You'll see two zones that are described or illustrated: the epileptogenic zone or seizure onset zone. In this case, you have 3 tracks that are represented. And you also see propagation zones or white matter tracks involved in the propagation zone. And so what I'm showing you is we're 3-dimensionally, we're able to depict the network, and we can incorporate that data into the neuronavigation system, similarly to what I'm showing right now, in order for surgeons to potentially target specifically the white matter tracks and spare completely the cortex. Another objective that we have is to try to quantify the connectivity within the different regions of the network. And so what we did is we quantified using classic or typical connectivity strength measures, the strength or the how strong connections are within the different networks. And what we found is that within the seizure onset zone and seizure propagation zone, the median connectivity strength value are higher than in the other zones of the network. And when we actually, which was not surprising because this is what our hypothesis was. When we look at specific comparisons, the main significant comparisons were when comparing the seizure onset zone and seizure propagation zone to the other zones. In other words, in the seizure onset and seizure propagation zone, the connectivity strength was higher than in the other zones. So what this suggests is that these findings could provide insights into the structural basis of seizure generation and propagation in a way that these two zones show increased connectivity strength. And this increased connectivity strength could potentially support epileptogenicity, both at onset and during spread. It could potentially also be used to help identify those two zones non-invasively. So we could imagine isolating in a patient the connection with the strongest connectivity strength, and this could potentially help us pinpoint the connections which are more likely to be involved in those two zones. And ultimately, this could guide or orient SEEG implantations. We also try to predict postoperative seizure control. And what we're doing right now is we're studying temporal lobe epilepsy patients that have been treated via an anterior temporal lobectomy. And while 70% of patients that undergo temporal lobectomy exhibit good seizure control, there's about 30% who do not. And this is probably due to the fact that the epileptic network extends beyond the resection cavity. And so what we're trying to do right now is to try to use the connectivity pattern and use that information to try to predict postoperative seizure outcome using a mask of the resection cavity that is planned, and simply classify patient into seizure-free and non-seizure-free. Another goal is to prevent neurological complication. And in order to prevent neurological complication, it's important to understand the function of the brain. One of the most recognized or described function of the brain is pain processing, which takes place in the posterior superior insula. This has been very well characterized from a cortical standpoint. What we've recently done is we've been able to identify the white matter components involved in pain processing. And so in patients with a collaborator from France, in patients with that underwent awake surgeries, we were able to stimulate the white matter fibers underneath the insula in the overlying operculum and elicit pain in those patients in a wake state. And we're able to reconstruct the white matter tracts involved, or the white matter tract that we stimulated, which ended up being the tract connecting the posterior operculum to the posterior thalamus. And so if we know where the tract is located, we can avoid entering surgery in order to avoid postoperative deficits, including central pain syndrome. This kind of goes in hand with a meta-analysis that we recently performed comparing tractography guided versus standard surgeries. And what we found is that when we incorporate information from white matter tractography into the neurosurgical workflow, there's a decreased risk of postoperative neurological deficits, which suggests that they could be useful, especially when operating in or near eloquent regions. So I have a few illustrative cases. So this is a 56-year-old right-handed male with a 2-year history of epilepsy. His seizure semiology consisted of focal impaired awareness seizures with a frequency of 2 to 3 per week, despite being on 4 anti-seizure medications. So the FLAIR MRI showed an extensive tumor located in the left frontal lobe. It was a low-grade glioma. And task-based functional MRI showed that language was located near or within the tumor itself. And so we're working in a very eloquent region, and therefore we wanted to perform an awake surgery to try to preserve as much as possible both the functional cortical regions and the functional subcortical regions, so the white matter tracts. So we therefore incorporated information from white matter tractography in the workflow. So we have a custom white matter reconstruction pipeline that we built in our lab, thanks to my amazing research associate, Guillaume Théo, and thanks to the collaboration with the Sherbrooke Connectivity Imaging Lab, so François Rio and Maxime Descoteaux. So we built a pipeline that's fully automated and that takes as inputs the DICOM coming from the MRI machine and is able to reconstruct up to 24 white matter bundles that are integrated directly into the neuronavigation system. And so this pipeline incorporate surgery flow, which is a homemade algorithm that allows us to reconstruct and segment the white matter bundles that will then be incorporated into the neuronavigation system. And so in this patient, we performed an awake surgery. So the patient consented to share the images. You can see here the positioning. I use neurophysiology during the case to try to understand as much as possible the location of functions. This is the craniotomy. You can see the tumor here. I'm stimulating different regions, and the labels correspond to the regions that elicited language dysfunctions. And also resected and stimulated deeper near the white matter tracts. And you can see that I'm guiding my resection using the white matter reconstructions or the tractography reconstruction incorporated into the neuronavigation system, as you can see here. So these are regions where I stimulated during the case. So using that approach, so tractography-based awake surgery, we're able to remove over 90% of the tumor in a very functional region with no postoperative neurological deficit. This is another case of a 30-year-old right-handed male with a 6-year history of epilepsy. His seizure semiology consisted of focal impaired awareness seizures with a frequency of about 5 per week, despite being on many anti-seizure meds. So scalp video EEG monitoring revealed both ictally and interictally that discharges were coming from the right temporal region. The MRI revealed bilateral periventricular nodular heterotopias, as you can see here, which are obviously epileptogenic lesions. We performed the kind of standard or the test that we always perform for almost every case as part of pre-surgical workup here at the SHIM, including PET, ictal, SPECT, and SYSCOM, MEG, and EEG fMRI. And the onset was, well, these tests suggested that the onset was probably located in the right perisylvian region. We also performed resting state fMRI network mapping thanks to our collaboration with the MNI. And what this showed is that the right occipital nodule was probably the one that was driving the epileptic network because it was the most connected to the other nodules. So we performed a unilateral SEEG study sampling all the suspected regions. And the study results showed that the network was a complex epileptic network. But the seizure onset was located in a single right occipital nodule, so the one that was suggested you're using resting state fMRI network mapping. And therefore, we proceeded with laser surgery in order to spare the overlying cortex as well as the adjacent white matter tracts where the optic radiations are located, which are important for peripheral vision. So we use preoperative planning using tractography, and you can see the relationship between the actual nodule and the optic radiations. We integrated the information of white matter tractography, the optic radiations, into the ablation software to see it in real time. And we performed our ablation that you can see here in blue, trying to spare as much as possible of the optic radiations. And you can see here the post-treatment MRI with the lesion that's partially enhancing here, which was very satisfactory, and closure using 2 staples. The patient had no neurological deficit, including normal visual fields, and remains seizure-free since surgery, which was performed a year and a half ago. This is another case of a 50-year-old woman with a 20-year history of epilepsy. Her seizure semiology were very interesting. They consisted of focal aware seizures that were optokinetic reflex seizures. So in other words, her seizures were induced or elicited by a change in visual contrast or color contrast. And what we found is that there was a lesion on FLAIR MRI. We see that there's a lesion, which is probably an FCD type 2, located just anterior to the primary motor cortex, near the superior frontal sulcus, right next to the right frontal eye field. You can see here the hyper-contrasted FLAIR images showing the FCD, including the transmental sign suggestive of FCD2B. So we planned the ablation using 2 trajectories in this case, as you can see here. And we incorporated, again, tractography data into the workflow. Especially, we tracked the white matter fibers that originated from the hand region of the primary motor cortex, because these are very functional fibers. And you can see the relationship between the FCD that's segmented in black and the actual white matter fibers that are illustrated in white here. So we needed to be very cautious. So we performed the ablation shown here in blue, sparing as much as possible the cortical spinal tract. You can see the post-MRI images showing good enhancement and pretty good ablation, which kind of matched with the planned ablation before surgery. The patient was discharged home on post-op day 1 with normal motor strength. So this is a 25-year-old male with right temporal lobe epilepsy on 2 anti-seizure medication. And the MRI was suggestive of a right mesiotemporal infiltrative lesion involving the amygdala and the hippocampus, as you can see here. And so we, again, performed preoperative tractography to understand the relationship between the optic radiation and the lesion itself. And so the optic radiations were located where they're supposed to be located, lateral to the temporal horn. And so since these fibers were preserved as expected, we opted for an approach that spared the lateral cortex, the lateral temporal cortex, and spared, therefore, the optic radiations, which are located right just lateral to the temporal horn. And we used a very novel approach, which is called a transorbital approach, in which we can have direct access to the medial temporal lobe via the inside of the orbit being the bony cavity that contains the eyeball. And so this allowed us to perform a selective amygdalohippocampectomy via that approach, with very good exposure and very good surgical corridor that I'm going to show you in a second. This is pretty innovative. It was actually accepted last week in JNS, and it's the first case of a selective amygdalohippocampectomy performed via that approach. So this is just to show you the surgery. So you can see here the incision in the eyelid. You can see the eyelashes here. So I perform the incision. I do that conjointly with one of my colleagues, skull-based surgeon. We work from inside of the orbit. The eyeball is retracted medially on the right side. We drill, open the dura, get into the temporal tip, open the ventricle, the temporal horn of the lateral ventricle. This is the amygdala that we're going to see here on the medial side, on the right side. I keep on resecting the anterior temporal tip, the pes hippocampus. We then remove more of the amygdala to expose the body of the hippocampus more posteriorly. The parahippocampal gyrus and subiculum under the hippocampal sulcus is removed. We can see the basal cistern, so the medial extent of resection. We resect more posteriorly the hippocampus above the hippocampal sulcus. We keep on resecting the parahippocampal gyrus more posteriorly. We expose the brainstem across the pia mater. You can see here more of the hippocampal body that we're resecting more posteriorly. And this approach is very interesting because you can reach the posterior hippocampus very, very far, more than laser surgery or even more than an open resection or open temporal lobectomy. See the choroid plexus here, and this is the final cavity that you see. Very satisfactory. So we're able to remove the entire amygdala, the parahippocampus, and the hippocampus very posteriorly. And then the surgeries, the closure is performed using fat and fibrin glue. So postoperative images here show the result. So you can see on the left side that we removed the entire amygdala and the hippocampus very posteriorly. And on the right side, you see the optic radiations that were preserved following surgery. It's just to show you the cosmetic results. So the patient consented to share the images. You can see here that, so the incision was in the eyelid, and this is 6 weeks post-op. And he remains seizure-free since surgery, which was performed 4 months ago. So the last objective is to try to predict postoperative functional recovery. And one of the regions that has a striking recovery is the insula. And so we studied insular epilepsy surgery. And what we found is that, by performing a meta-analysis, is that a lot of patients following insular epilepsy surgery develop neurological complications, but the vast majority of them recover fully and rapidly within 3 to 6 months. And this is kind of peculiar. So we wanted to study this striking recovery. And so what we did is we scanned patients with opercular insular epilepsy that were operated multiple times before and after surgery and performed a longitudinal analysis of connectivity using a comprehensive pipeline. And what we found is that there's an increase in connectivity strength in connections around the resection cavity and on the contralateral side. And these changes occur within 6 months, which corresponds to the time frame of functional recovery that we see. And so potentially these connections that show increased connectivity strength kind of emerge to supplant the function of the injured opercular anterior region following surgery. And so these connections are potentially important to spare in order to lead to functional recovery. And so in conclusion, poorly controlled epilepsy, as I mentioned, is a very prevalent disease. As most of you know, seizures are debilitating and they're unpredictable, are associated with cognitive deficit, psychiatric conditions, psychosocial handicaps, and an increased risk of mortality. And surgery is obviously beneficial, but is imperfect. And so if we can improve the selection and the surgical treatment, that would be ideal. And since that paradigm shift towards the epileptic network, I think that imaging-based connectomics, especially using multimodal MRI approaches, which are completely non-invasive, this could be very useful. And as I kind of alluded to, this could try to help optimize seizure control, avoid useless surgeries, and potentially decrease postoperative complications, and ultimately improve the clinical outcome and quality of life of affected patients. So I want to thank my clinical team at the SHIM. I'd like to thank also the research team, who, students are the ones who do the work. I'm just there to supervise and have lunch with them. And also a big kudos to Guillaume Thibault, my research associate, who does a lot of the work as well. Thank you.
Thank you very much, Sami. That was an excellent talk and really innovative work in surgery. I don't know if anybody in the audience has questions. I think John has a question.
Yeah, can you hear me okay? Yeah, thank you. Very nice. One of the things you alluded to, of course, was the fact that you may get an epileptogenic network, of which obviously the basis is the white matter. Do you think that you could have a plan rather than resecting? You kind of touched on this, but it kind of made me draw you out on the temporal lobe. So do you think perhaps then that for a temporal lobe surgery, you could identify specific tracts and plan to disconnect them rather than to focus on the resection? So for example, you might elect to disconnect the connections of the piriform cortex to the frontal lobe. You might elect to disconnect the anterior part of the ventral cingulum.
Absolutely. Very good question. Thank you. There are some papers on that, try to resect specifically the white matter tracts, or disconnect, I should say. I think that the best way to do it would be using non-invasive approach, for example, laser, because you can completely spare the cortex to do so. I think that this is where we're going to. If we're able to characterize the epileptic network precisely, we could potentially only target the white matter tract, just like you suggested. And it could have a significant impact on patients, a positive impact, because we can imagine let's create a purely artificial network that connects the Broca's area to the primary motor cortex and to another functional region. Potentially, we know that all these regions, cortical regions, have an important function. So resecting Broca's area will lead to language deficit. Primary motor cortex will lead to motor deficit, and so on. But if you keep the cortical regions and the white matter tracts that are involved in the functions, for example, language function and motor function, but you disconnect the connection between the two, you could potentially treat epilepsy while preserving the function of those specific regions. So that would be the goal. There's many steps to go, but that would be amazing. Absolutely. Yeah.
Yeah, but I think that can go wrong, of course. I mean, you showed us very nicely that you were avoiding the arcuate fasciculus in your frontal lobe resection. I mean, we know very well that if you leave the grey matter intact and you cut through IFOF, for example, or you cut through the arcuate, you're going to get a severe language difficulty. So I think nobody should go away with the idea that so long as you spare the grey matter, take out the white matter, everything will be well.
No, I mean the non-eloquent white matter.
Yeah, that's the key thing. I mean, you showed you showed the importance of sparing Mayer's loop in that nice hippocampal resection. I guess the key thing for me is how you determine whether a white matter tract is indeed essential for a function, and or whether it's transmitting epileptic activity.
That's a very good question. As most of you know, the actual function of the white matter tract is not well described. The best data that we have on function of white matter tracts comes from awake surgeries, during which we stimulate, the tracts, and we elicit responses, and we perform tasks during surgeries. This comes with a lot of problems. Obviously, patients can only stay awake for 2 to 3 hours. You cannot perform complex neuropsychological tasks. There's some brain shift during surgery. Patients are slightly sedated and so on. So there's a lot of problems with this approach, but this is the best, quote unquote, that we have now. When we start understanding the function of these white matter tracts in, quote unquote, healthy states, then we will potentially be able to use that approach. Yeah.
Yeah, thank you.
That was great, Sami. I have one question. What is your imaging protocol for diffusion MRI, and how reliably can you reconstruct those tracts?
Good question. So we have a simple, quote unquote, protocol. We used to do single shell Hardy, so high angular resolution diffusion imaging. So we have 60 direction, 1.8 millimeters diffusion DWI scans. And we have 1 millimeter T1 images that we use, and at B1500 for diffusion images. I mean, how reliably? Very good question. That's we believe that we have good results. I mean, we compared our methods, or I should say, our methods have been compared using cadaveric dissection, which is quote unquote supposed to be the gold standard. But as you know, this is associated with a lot of biases. But I mean, what I can tell you is that when I stimulate white matter tracts during surgery, awake surgeries, this is very qualitative, but I tend to have responses. So I quote unquote believe it. But I mean, we would need obviously quantitative measures to confirm what I'm saying.